We did have a lecture about anemia. That lecture covered the theory and the knowledge, the theoretical knowledge of anemia. Now we are going to deal the diagnosis of anemia. How you are going to diagnose an anemia. What kind of key features you have to use to diagnose an anemia. At the beginning, the definition is identical, meaning that the number of the circulating red blood cell count decreased. This number is determined by your gender, whether you are male or female, and where you live. So this is why this is important to know these clear-cut values. As you know that based on the red blood cell count, in males, if it's less than 4.4 tera per liter or 4.4 milliamp per microliter, or in female 3.8 tera per liter or 3.8 milliamp per microliter, or the hemoglobin is about less than 140 gram per liter, or in female less than 130 gram per liter. In hematocrit, that's about 0.42 or 0.37. One very important, it's a very, very common disorders. However, it is mostly secondary. This is not the underlying cause. This is not a primary disorder. That's only a consequence of a disease. So if somebody has anemia, you have to figure out what caused the anemia. So you cannot be satisfied by diagnosing anemia because this is not a diagnosis. This is only a clinical sign. That's it. Now, it's not an easy to find out the cause, and sometimes not an easy to treat it. But you have to think about it. This is a very common disorders and secondary, always a secondary disorders. Now, signs of anemia. We already discussed some sign of anemia, but some sign, what you can see on the patient, that's be the consequence of anemia, but some can tell you the cause of anemia. For example, let's see some consequence of anemia, for example, the central nervous system. If you have fatigue, dizziness, or you can faint if you do have very severe anemia. But look at the eye, the sclera. If the sclera is yellow, this can tell you that hemolysis or increased bilirubin. So you figured out that anemia could be due to hemolysis. On the skin, very similarly, the sign of anemia or consequence can be paleness or can be coldness because the sympathetic stimulation, the peripheral vasoconstriction occurs, but can be yellowing again due to increased destruction, bilirubin level. Exactly. Respiratory system, because we do have hypoxia. Hypoxia stimulates the breathing center. We have tachypnoea, usually very short and very frequent, let's see, breathing. Muscular weakness. Muscular weakness can be obtained. Less oxygen, less myoglobin, less strength of the muscle. Intestinal problem. Change color of the stool. Can be bloody, can be black, can be, for example, tar-like. A lot of things can means that some cause, bleeding, for example, or hemolysis, for example, that could cause the anemia. Spleen enlargement, that can be the cause or can be the consequence, for example, of immune-mediated anemias. Blood vessels, because we do have less circulating red blood cell count, we do have less peripheral resistance. This is why mostly is accompanied with a lower blood pressure. However, because tachycardia occurs, so the velocity of the bodies increases, this is why you can hear some systolic noise, systolic murmur, for example, in the carotid area. That can be again another sign. Or heart, due to hypoxia, tachycardia, sympathetic stimulation, or palpitation, tachycardia. And in very severe case, especially when you do have a narrowing of the coronary, angina pectoris or myocardial infarction can develop. So a patient who has anemia can die due to myocardial infarction because the most sensitive organ to the hypoxia can be the heart. If you look, if, let's see, if you do have a completely healthy person, relatively the clinical sign of anemia almost none, maybe dizziness. But when you are an old one and you do have some narrowing of the coronary, well, you can have myocardial infarction. Another thing, when you do have blood loss, what will be the consequence of the blood loss? Increased sympathetic activation, peripheral vasoconstriction, everything goes to the heart. Yeah, but if you have less oxygen carrying capacity left, doesn't matter how you are going to direct the blood to the central organs, if they cannot take enough oxygen, they can damage. So this is why anemia can be a severe one and can cause deficiency. Now, this is what we already said during the lectures, that the pathophysiology of anemia can be decreased red blood cell production, so we are not producing enough, or we producing enough, but we are losing too much. That can be the problem. Or this sequestrating the red blood cells, for example, the spleen. As a decreased production can be due to the stem cell, can be the mediators that is going to regulate the erythropoiesis, or problem in the hemoglobin synthesis, or defect, for example, in the DNA synthesis in the cell maturation. In increased loss, mostly due to hemorrhage, for example, or due to hemolysis, some kind of increased destruction. Now, what kind of lab examination we are going to do to identify the type of anemia or the cause of anemia? First of all, as we mentioned before, they are going to do the blood test, the complete blood count. Automated system. This is what you will get. This is a normal picture of a normal blood count. They are going to determine the red blood cell count, hemoglobin, hematocrit, reticulocytes, as we said, the RDW, the relative distribution width, mean corpuscular volume, MCH and MCHC, what you can see here. As you see here, however, you do see the white blood cell count, and you do see the platelets, and here this relative distribution with what you do have here. Blood test, not only the blood counting, but the blood test. For example, the iron metabolism is usually checked because the most common type of anemia is iron deficiency anemia. So checking the serum iron, ferritin, total iron binding capacity, transferrin saturation, and the soluble transferrin receptors. These are going to be checked. To check hemolysis or destruction of the cells, they are going to check LDH 1 and 2. The isophore 1 and 2 should be checked because that can be found in red blood cells. They are going to measure the serum bilirubin. Mostly the indirect is going to tell you that that's a hemolysis, or haptoglobin or hemosiderin. That's going to tell you whether that's an intravascular hemolysis. In this case, haptoglobin hemopexy level decreases. If you do not have any changes, that could be extravascular. Extravascular means that directly is phagocyzed. Intravascular means that inside the circulation destroyed, and after the bilirubin is uptaken by the phagocytic system. Coombs test is used to identify the autoimmune origin of the immune-mediated hemolysis. Urine test, UBG, hemoglobin, hemosiderin measured. And sometimes they use the blood smear test because, as we said before, the blood count analyzer cannot identify the shape abnormality, the inclusion. So this is why sometimes the smear is needed. Now, what is the relative cell distribution width? Basically, the automated cell counter is going to measure the size of the cells and the number. So they are going to tell you or going to show you the distribution of the cell counting. And we do have a standard deviation, basically how wide this Gaussian curve is. And we are going to divide the standard deviation by MCV. This is how we are going to detect the RDW. Normally, we do have about 13. That's a normal value. If this value is higher one, meaning that this curve wider. What does it mean? It means that you do have different size cells. So they are not unique. This is what we call anisocytosis, when we do have different size cells. Mostly happening if we do have some kind of production problem of the red blood cells. Reticulocyte number. Why is it important? Because every red blood cell enters the periphery in the form of reticulocytes. So if you want to evaluate the production of the red blood cells or the erythropoiesis, what you have to do, count the reticulocyte count. Normally about 1 to 2% that we do have. Now if you do see more reticulocyte count, but you are ending up anemia with less in the periphery, what does it mean? You do have a hyperregenerative anemia, meaning that you do have an increased production because they want to contract with the elimination of the red blood cells. So this is why the bone marrow is it's stimulated by hypoxia. However, if the reticulocyte count is lower than it should be, that means hypo or regenerative anemia, when it's meaning that the bone marrow is not able to produce as much red blood cell that is needed. So this is why the reticulocyte count is important. However, let's see. Why the reticulocyte count can be increased? There is two reasons. One, we do have an increased production rate. Okay? So when we do have hypoxia, hypoxia is going to stimulate the erythropoietin synthesis. Erythropoietin is going to stimulate the precursor formation, so the dedication toward the erythroid cell line, and shortening the maturation. Meaning that you don't need to wait for 7 days to form one reticulocyte. It's enough, for example, to 5 days or 3 days. However, you can enter, let's see, the cells earlier into the periphery, but the reticulocyte stays longer in the periphery, meaning that they're still going on some hemoglobin synthesis, so they are still going enzyme synthesis. Normally it takes about 1 day, 24 hours, when they are going to lose this reticular filamentosa. So when they are losing the ribosomal remnant. However, if you have a younger reticulocytes get to the periphery, it needs maybe 2 days to lose it. So the accumulation can be due to the increased production or a longer lifespan or longer stays in the periphery. This is why the reticulocyte index is introduced, because this reticulocyte index is corrected by the lifespan of the reticulocytes in the periphery. If you do have a very severe anemia, when the hematocrit is very low, this stimulation is so, let's see, strong that the reticulocyte stays almost 2.5 days in the periphery. In the normal case, only 1 day. This is how they are going to correct it. Now, based on this reticulocyte index, if it's less than 2%, that means underproduction. So something that's a hypoproliferative bone marrow. However, if you do have higher than 3%, meaning that the bone marrow is stimulated. So it's meaning that hyperproliferation is going on. However, something is going to decrease the red blood cell count. So we do have an increased destruction or loss of the red blood cells. So this is how you can start the evaluation. This little algorithm, diagnostic algorithm, is going to tell you how you are going to use this reticulocyte index. If the reticulocyte index is higher one, the next question, for sure, what is the cause of this increased production? This is due to bleeding. Let's see. If you can see the bleeding, it's fine. If you cannot see the bleeding, now that won't be so easy to detect. For example, occult bleeding, the GI tract, or hemosiderosis, or hematuria, or some additional problem when they are going to lose red blood cells. If not, next question, is the serum LDH activity is higher? Or is the serum indirect bilirubin level is higher? haptoglobin decrease, so that's a direct, let's see, findings of hemolysis. And if you found that, yes, hemolysis is going on, now you have to look at the risk factors. Can you see something that drugs or other poisoning that can cause the blasting of the red blood cells or not? Or it's an autoimmune? Do the Combs test. If not, let's see, best one to review, let's see the smear, because something immediately can be read out from the shape of the red blood cells. We shall talk about later. If we do have an underproduction, what this means, only based on the mean corpuscular volume, we can identify the possible cause of this underproduction. And of course, you have to review the risk factors or review, let's see, the smear if it's needed. Now, the Anemia Workup based on the MCV. I mentioned on the lecture why the mean corpuscular volume is smaller one, especially when we do have a hyporegenerative anemia, because we do have less hemoglobin in it. If you do have less hemoglobin, you have less packing in the red blood cells, they are smaller one. So if you look at these problems, this associated with a lower hemoglobin synthesis. The most common one, iron deficiency anemia, or thalassemias, hemoglobinopathies, or sideroblastic anemia. So they are all or be microcytic one. In some case, for example, chronic inflammation again can cause microcytic, but it's mostly normochromic and normocytic anemia. Another big group when we do have the problem with the maturation. So these are, for example, the normocytic normochromic anemia and aplasia of the bone marrow, or for example, leukemia is going to impair the bone marrow, or hemolysis, bleeding, or renal diseases, or chronic inflammation, or systemic chronic diseases. These are all influences, let's see, the number of the cells, but they're not going to interfere too much about the hemoglobin synthesis. When we do have a macrocytic hyperchromic anemia, very commonly we do have vitamin deficiency such as the B12 or folate deficiency. This is called megaloblastic anemia. It's not the same as macrocytic anemia. But liver disease or alcohol, again that can cause macrocytic one. Metabolic disorders such as, for example, hypothyroidism, again that can cause macrocytic anemia. Or myelodysplasia, myelodysplastic syndrome, again that can cause macrocytic anemia. So this is how we are going to start to discuss this. Now this is how normally a peripheral smear looks like. As you see here, the red blood cell size is very unique. You do see some altered red blood cells, such as a fragmentocytes, what you can see, or helmet cells, but not too much. This is due to, for example, when you make the smear, the damages the cells. But mostly they're unique in size, unique in shape, so this is the normal peripheral picture. Now, I mentioned that this is what you cannot identify based on the cell counting, automated cell counting method. You cannot see is any kind of occlusion or any kind of shape abnormality occurs in the smear or not. For example, very common one when we do have this basophilic stippling, when we do have this RNA remnant inside the red blood cells, that mostly can be used, for example, the lead or heavy metal poisoning, or myelodysplastic syndrome, or sideroblastic anemia. And immediately, if you had the smear, you can see it. Another type of, let's see, this red blood cell shape. As you see here, this is the echinocytes or Burr cells, or Burr cells. When we do have the altered lipid cell membranes, that is going to, this is a spikes membrane structure. Of course, they do have a higher rate for hemolysis as well. But it can be due to uremia, for example, not only liver problem, or if the cell does not have any pyruvate kinase, for example, enzyme, or they have less. But if somebody had, for example, the transfusion, again, the old transfusion cells can look like this. So figure out. Another, these elliptocytes or ovalocytes that can occur, for example, in megaloblastic anemia, as you see here, another very typical sign of megaloblastic anemia in the periphery, such as the hypersegmented neutrophils. If you do have the segment number is more than 4, that can mean that the hypersegmentation, and that can be the sign of megaloblastic anemia. But when we do have an abnormal cytoskeleton, or it's a hereditary elliptocytosis, what will be the consequence? Again, increased hemolysis. Howell Jolly body. Howell Jolly body, that's a nuclear remnant inside the red blood cells. That can be due to, for example, megaloblastic anemia, or if somebody, for example, had splenectomy or spleen hypofunction. But if we do have a severe anemia, severe hemolytic anemia, we do have a very highly stimulated erythropoiesis, and we do have erythropoiesis in the, let's see, in the liver or in the spleen. So out of the bone marrow, it can happen, and this is why we can have, for example, nucleus or nuclear remnant inside the red blood cells.
But it can be not in the bone.
Okay, so this is that we call as a Howell Jolly bodies, and again, that's very informative. Here you can see the schistocytes or helmet cells as the helmet cells, or this is a fragmentocytes as well, usually meaning that the mechanical destruction of the red blood cells. So this you can explain that's an extracellular problem or extracellular cause of mechanical destruction of the red blood cells. That can be due to DIC, TTP, or HUS, or vasculitis, or post-hepatic heart wave, for example, or severe burns. So a lot of things can cause the destruction of the sickle cells or nucleated red blood cells. Look at the sickle cells. You know that the cause of the sickle cells anemia is due to the point mutation of the globins. Now we do have a hemoglobin S that is going to be polymerized in a carboxylated hemoglobin. So when we are going to release all oxygens in the periphery, and when this polymerized hemoglobin is going to give a rigid structure of the red blood cells, and this red blood cells is going to take the shape of the capillaries. However, it's not flexible, it's not going to jump back to the, let's say, the previous biconchal area. So this sickle cell stays, and during the next passage, they are going to plug the capillaries, and that can cause necrosis and certain, let's say, organs. And this is very painful depending on which organs are affected. Nucleated red blood cell represents, again, a very highly increased red blood cell production, such as we said, for example, in hemolysis that due to sickle cell anemia. But in other thing, newborn is completely normal one to see some kind of nucleated red blood cells. And however, in adult one is always pathologic. So this is why you have to suspicious about the hemolysis or bleeding, or if we do have some kind of bone marrow barrier problem that is due to leukemia. So in adult one and nucleated red blood cells, always pathological condition. Spherocytes, look at this round-shaped and very highly stained hyperchromatic red blood cells. These are the spherocytes that relatively that can be immune-mediated or can be hereditary spherocytosis, and in the middle you don't see this pale area, and of course more hemolysis. So this patient usually has a more fragile red blood cell because these spherocytes difficult to go through the capillaries, and the spleen is going to destroy them very early and very easily. Stomatocytes looks like as a mold-like shape of the red blood cells. This can be membrane defect or can be artificial one. That can be hereditary as well. And again, increased hemolysis again. Red cells is not normal in shape. They do have a higher chance to be destroyed. Now, target cells or annulocytes. This is the annulocytes when you do have a bigger pale area in the middle of the red blood cells. Now, the target cells is meaning that we do have a little hemoglobin content in the middle of this pale area. And that can be due to hemoglobinopathies or very severe iron deficiency and obstructive liver disease. So again, or thalassemias, this is very common one and immediately can be diagnosed based on the peripheral. Teardrop cells. Teardrop cells, it looks like as a teardrop. Now, that's sometimes is artificial or bad. It can cause or can be due to myelofibrosis or any occupying process that usually occupies the bone marrow, for example, metastasis, and so on and so on. So this is a teardrop cell. So again, more chance to destroy it in the spleen or in the periphery. Now, if you are lucky and you do see some kind of, for example, creature inside the red blood cells, such as a Plasmodium vivax, that again you can diagnose malaria. So you can identify what could be the cause of, for example, a hemolysis that occurs in paroxysmal. Now let's start and let's discuss the different types of anemias. So we are going to start with an underproduction or the hyporegenerative anemias, such as and the microcytic anemia. We know that microcytic, normocytic, macrocytic anemias. Let's see the. Okay, this platelet count is still normal. However, you know that when we do iron deficiency anemia, we can have increased platelet count. Why? Because when you do have hypoxia, hypoxia stimulates erythropoietin. Erythropoietin is similar to thrombopoietin, and if you do have a very high level of erythropoietin, that cross-react on the platelet on the surface of the megakaryocytes and acting as thrombopoietin. So we are going to make more platelet. So don't be surprised if you do find, for example, a thrombocytosis in a case of iron deficiency, because this comes together. Now, iron deficiency. The most common hematologic disorders, as I mentioned, but this is not a disease. Mostly depending on age, but in adult one, the most common cause of iron deficiency is GI bleeding. Another very important one, negative blood test proves nothing. So if you are going the hemocult or Weber test of the patient's stool and you are identifying nothing, so you cannot show the presence of the hemoglobin in the stool, it does not mean that the patient doesn't bleed or does not have occult bleeding. So you have to perform colonoscopy, gastroscopy immediately to exclude any kind of GI problem. In women, not only this, but for example, from Willebrand disease or myoma should be excluded as well. Now, in healthy individual, for example, during pregnancy or strong menstrual cycle, they need extra iron. They can develop iron deficiency. Or other case, if somebody is suffering of parasite infection or malabsorption or low iron intake. Now, who can have low iron intake? Vegetarians, for example, because the most absorbable iron is a heme bond iron. From other, for example, from vegetables and other, the iron cannot be absorbed, and relatively they contain less. And there are some substances that is going to bind the iron. For example, the tea, for example, if you do have a tea, you are drinking a lot of tea, you can have a tannin content of the tea. The tannin is going to bind the iron, and this is left for you. Okay. Let's see some other special tests for iron deficiency. For example, the ferritin. What is the ferritin for? This is how the iron stored in the body. So the stored iron usually reflected by the serum ferritin level. If you do have any kind of iron deficiency, or you do have a latent iron deficiency or pre-latent iron deficiency, the transferrin level is going to decrease. So this transferrin be the most sensitive way to detect iron deficiency. Now, next one, total iron binding capacity. What does it mean? We do have the transferrin. This is going to transfer the iron. And this transferrin usually is binding the iron. Depending on how much iron you have, that's going to bind, that's going to saturate the, let's see, the transferrin, the normally about 20 to 50%. And the total iron binding capacity is measures the free binding site that is not occupied. Now, how can it be higher? If you do have less iron in the blood, so you do have less occupied binding site in the transferrin, or you do have an increased transferrin level. For example, if somebody has iron deficiency, for sure the transferrin level is going to increase because you are very hungry to take the iron, and from the intestine they want to resolve more and more iron. Normally we are going to resolve about 10% of the intaken iron. So usually you are taking about 10-20 milligrams iron per day, and this 1 or 2 milligrams is going to be absorbed into the blood. However, if you do have iron deficiency, that can be increased due to the extra binding site. But because the, let's see, the transferrin is less occupied with iron, this is why the total iron binding capacity, so the free binding space, is increased. So exactly changing oppositely based on the iron level. Serum iron, this is a free form, or the transferrin bound form, that is less than 5% in iron deficiency, and the saturation usually is less. This is what is going to. Now that's a summary how we can identify, how can we differentiate other type of iron deficiency, and that is called iron deficiency associated with chronic diseases. Now, let's look at the serum ferritin. If the serum ferritin is low, fine, you know that this is iron deficiency. If the serum ferritin level is high, but your serum iron is low, that is due to chronic disease-associated anemia. If you are in the normal range, let's measure the total iron binding capacity, and if it's, let's see, high, that's iron deficiency. If it's low, that's chronic disease-associated one. Because what will be the first sign when we do have an inflammation? Transferrin level is going to decrease because transferrin is a negative acute phase reactant immediately. Now, this is a summary that is going to help you to figure out the case studies. So, iron deficiency, microcytic one, anisocytosis, hypochromic, reticulocytes index is low, so it's a hyporegenerative. Reticulocyte count, it can be increased or not, but the reticulocytes index always low. Serum ferritin is always low. Total iron binding capacity is increased. Serum iron is low. Soluble transfer receptors increased. This soluble transfer receptor is located on the surface of the erythroid precursor cells. This is how they are going to get the iron from the transferrin. If you are hungry, if you need more iron to incorporate to the hemoglobin, the cells is going to express more receptors, transfer receptors, and more is going to shed it into the bloodstream. So the soluble form is going to increase, representing more need iron in the bone marrow. Now they do make a ratio at the soluble transfer receptor over the log ferritin, and if it's a higher one, that higher than 2, that means iron deficiency. If it's less than 2, it means chronic iron deficiency, chronic disease-associated iron deficiency. The bone marrow iron staining usually is not performed today. And another thing, if you give iron to this patient, is going to basically respond to the therapy. How? Increasing reticulocyte count immediately. All right? So this is how you can check it within 1 week. Now this summary is going to tell you how the serum iron, total iron binding capacity, and ferritin is going to change in the different most common form of microcytic anemias. In iron deficiency, we said serum iron down, total iron binding capacity increased, and transferrin is going, and the ferritin is going to decrease. In case of chronic disease, let's see this first. In chronic disease, we do have less iron, fine. We do have less total iron binding capacity. Why? Because we have less transferrin. And the ferritin level is increased because we do have the hepcidin, and hepcidin does not let the stored iron get out from the white blood cells. In thalassemia or sideroblastic anemia, again, we do have a problem with the heme synthesis. So the iron cannot incorporate into the heme. So what will happen? The serum iron level is higher one. Because the serum iron is higher, occupies more place. So the saturation of the transferrin is higher one. So the TIB is less. And the ferritin level is high because this extra iron gets into the stores. Thalassemias is depending on how severe the thalassemia is. If you do have an increased hemolysis, for sure the serum iron level increased. If you do have hemolysis, the TIBC decreases because occupies more binding places on the transferrin. And the ferritin, again, it increases because it's stored. If it's not highly elevated, the hemolysis, there is almost no changes in this situation in thalassemias. We do have a case, let's see and let's read it. We do have an 84-year-old woman, known and treated diabetes and hypertension. In the last half year, she had changing stool habits, obstipation, altering with diarrhea. She also felt stomachless and she lost weight. The family doctor has found anemia and referred her to the specialist. Now, he was very clever. When they evaluated this patient, they saw that the mucosa was pale and the conjunctiva was pale and lymphatic nodes wasn't palpable. Good. Heart rate is 100, so she had tachycardia. Usually elderly, they do have low heart rate. They usually has less than 60 heart rate, unless they have problem. Ischemic sign on ECG. What kind of ischemic sign can be on ECG? We do have, for example, flattening of the T wave, inverted T wave, ST depression, or arrhythmias. All right, this can be ischemic sign. Abdomen is palpable under the left ribs, a fist-sized, thick resistance, normal bowel sound, no abnormal abdominal pain. Good. So something. Look at the data, the lab data. They found normal white blood cells. They did find a low red blood cell count. They did find a lower hemoglobin content, lower hematocrit content. The platelet count is elevated. Up to 400 tera per liter is normal, but it's 423. MCV 66 decreased. MCH, the content of hemoglobin in one red blood cell, decreased. Concentration decreased. And RDW increased. So this is a typical picture of an iron deficiency. Direct circumstance is negative, blood type is Rh positive, and Weber test negative, meaning that looks like they did not find any blood in the stool. But as we said, does not matter what the hemocult of Weber test shows, you have to exclude the GI bleeding by doing colonoscopy or rectoscopy. Now they did first ultrasound, of course, because that's the cheapest one, and they found, let's see, a little solid tumor in the left hypochondrium, which multiple intestinal contours can be seen as well. Colonoscopy showed that this patient had a, let's see, a tumor in the colon transversum with a cartilage hard consistence, and this patient had a little polypus, about 25% from the anus. Biopsy was taken and the tumor was diagnosed. Had, for example, neoplasm of the colon, and of course the therapy, transfusion, and should be removed, let's see, this tumor. Now, they are not going to operate the patient unless they have a normal, let's see, hemoglobin concentration, because the blood loss, extra blood loss, can cause further anemia and can kill the patient. That's true. Underproduction when we do have a normocytic anemia. Let's see. This algorithm is going to tell you what you should do first. So if the blood test comes back that you do have a normocytic normochromic anemia, the next question, the most common one, kidney problem. Let's check the creatinine. Is high or not? If it's high, well, kidney. So this anemia is due to kidney, chronic kidney disease. Let's evaluate the kidney function. If not, look at, do we have a pancytopenia? We do have a decreased white blood cell count and decreased platelet count. Okay, if it's so, possible is due to some kind of neoplasia or aplasia of the bone marrow. If not, do serum electrophoresis, protein electrophoresis. That's an immune-mediated process. If it's, let's see, you do see this abnormal M spike, monoclonal spike in the gamma fraction, that means multiple myeloma. If not, the patient could have, let's say, a chronic disease-associated anemia or sideroblastic anemia, and you have to perform bone marrow aspiration. This is how you go with this. Macrocytic anemia. Macrocytic anemia, when the size of the red blood cell is big, bigger than 100 femtoliters. Red blood cell count decreased, hemoglobin content decreased, hematocrit decreased. Inside one red blood cells, you do have an elevated, let's see, hemoglobin, and the size is bigger one. Good. RDW is normal. Well, how can be RDW is normal when you can see that this Gaussian curve is wider one? Because what was the definition of the RDW? Standard deviation divided by the MCV. Here, the standard deviation increased, but MCV increased as well. So because you are going to divide the higher value with a higher number, this is why it's not changing too much. So in macrocytic anemia, the RDW cannot represent nicely the anisocytosis, what you can see in a smear, for example. Now this is how macrocytic anemia looks like in the periphery. You can see, for example, big cells, small cells. How do we call when we do have the size differentiation or size differences? Anisocytosis. You can see again poikilocytosis because you do see spherocytes. See this elliptoid, spherocytes. You can see another, looks like there is no pale in the middle. That means hyperchromic one. And poikilocytosis and hyperchromia, you can see it very nicely. Now, how we are going to evaluate a macrocytic anemia? First of all, you should check the level of the B12 and folate. If so, we do have a megaloblastic anemia. That is called megaloblastic anemia. And you should check the TSH because most common disease in the thyroid diseases, primary hypothyroidism, and influences the basal metabolic rate, a macrocytic anemia can develop. If you found out, you can treat the underlying problem. Now, however, the next question, if the B12 level is normal or higher, because if somebody does have, for example, liver cirrhosis, liver damage, mostly that is very well correlated with the serum B12 level. Wow, it's great. Why? The total B12 of the patient is low. However, the serum B12 is high. Why? They believe that the carrier protein or the binding protein level decreases because the liver cannot synthesize enough protein. So this is why it's associated with a falsely increased serum B12 level is very well correlated with the B12. So if you do have an increase, for example, AST level, ALT level, the B12 level usually is high if you do have a chronic liver problem. That's not an intrinsic factor. Intrinsic factor, this is needed for B12 absorption. It's nothing to do with liver. That's something to do with the gastric parietal cells, because that's going to synthesize the intrinsic factor. If you don't see any problem, you have to go for checking the medication, because some drug, for example, methotrexate, is going to alter the folate, for example. The folate absorption is going to inhibit. Or not, again, back to the bone marrow, possibly is the myelodysplastic syndrome that we have. Megaloblastic anemia. Macrocytic anemia is not the same as megaloblastic anemia. Now let's see what the difference is. Macrocytic anemia means that we do have a larger red blood cell in the periphery. That's a peripheral diagnosis. Megaloblastic anemia, that's a bone marrow diagnosis. Okay, what is the problem with megaloblastic anemia? This is due to low level of B12 or folate. So what is the function of the B12 or folate? Usually is taking place in the DNA synthesis. If you cannot synthesize DNA, what will happen? You do have less red blood cells by the end. Hypoxia stimulates, let's see, the dedication of red blood cell. Again, you do have a lot of blast, but the blast should proliferate. However, they have to wait, This division window is open for a certain time. If you cannot duplicate the DNA, the cell is going to die. So, we do have a lot of precursors, but less cell is going to mature. So this is why it's called megaloblastic anemia, because the early stages is going to increase. So not only the red blood cell is altered, but the white blood cells as well. So we do have bigger white blood cells. And usually we have less white blood cells. We do have less platelet. So mostly a megaloblastic anemia can cause a pancytopenia. And in this case, usually they are going to perform the bone marrow aspiration as well. And because a lot of cells is going to die during the maturation, so the ineffective erythropoiesis is going to increase. This is why the LDH activity is higher one in this patient, plus the indirect bilirubin level is higher in this patient. So B12 deficiency, now this is how it's going to develop. Let's see. Basically, we need intrinsic factor. This is what we said so far. Parietal cells going to synthesize intrinsic factor. Intrinsic factor is going to bind to the B12, and this is going to help to absorb the B12 in the terminal ileum. Now, what can cause the deficiency of B12? Well, no intrinsic factor. Why? Possible we do have a gastrectomy, we do have terminal ileum resection, no malabsorption, anything. Or, very commonly, we do have an autoimmune disorders when the autoantibodies is going to bind to the parietal cells, causing a chronic inflammation, or bind directly to the intrinsic factor. It doesn't let to bind the B12. There's no absorption. And that disease is called pernicious anemia. Folate. Well, folate usually is obtained from green leaves, folium, green leaves. It's absorbed from a jejunum, and the most common, well, it's very rare that you are not taking enough unless you are pregnant one, because during pregnancy you need extra folate. This is why they are using preventively folate. They have to substitute the pregnant woman with folate. If somebody treated with drugs, as I mentioned before, methotrexate, for example, that antagonize folate, or malabsorption, for example, or alcoholism, again, that interfere with the folate absorption. Now, if you compare these two causes, there are some striking difference. For example, B12. B12 can be developed in vegetarians because the most common source of B12 is animal source. If they are not eating, yeah, they are eating some pears or they are eating nuts, fine. We do have a huge store for B12. So if you start eating any kind of B12, you need years to develop a B12 deficiency. However, folate, we don't have a bigger pool, plus we need much more folate per day. This is why if you stop eating folic acid, for example, or folate, that lasts, for example, 1 or 2 months to develop folate deficiencies. Very shortly after, let's see, the inappropriate intake is going to change. Now, B12, in case of the B12, at the cellular level, for example, very characteristic, the methylmalonic acid level increases because not only the DNA synthesis involves the B12, but the myelin synthesis as well. If you do not have a normal B12 level, the myelin synthesis is abnormal, and neurological symptoms can occur. So, for example, a vegetarian who never has any folate deficiency, they are not going to develop anemia, but they're going to develop neurological symptoms. Usually, for example, walking disorders, for example, they develop because the long pathways are influenced, the demyelination can occur, and the patient cannot move normally. In folate deficiency, when you don't have enough folate intake, yeah, you develop anemia very nicely, but you don't develop neurological symptoms. That's very difficult. Now, at the cellular level, how do we measure, let's see, this component? B12 can be measured in the serum very nicely because that will tell you how much in the stores. However, folate, the serum in the folate is not going to tell you something else. It only tells you how much folate you ingested today. That's it. So this is an acute folate intake reflected by the serum folate level. In the store, if you want to measure this in the stored, measure the stored folate, you should measure in the whole blood or you should measure in the red blood cells. So these are two different methods that you have to use it. Now, at the cellular level, whether it's acting or not, the homocysteine should be measured in the folate deficiency. Now, this cartoon is going to represent the role of B12 and folate. As you see here, the folate is very important in the DNA synthesis. So the tetrahydromethylfolate that is going to give the methyl to the enforce the thymidine and the pyrimidine synthesis. And B12 is going to regenerate the folate cycle, so remethylating the folate and trapping the folate inside the red blood cells or inside the cells. And in another case, we do have this methylmalonic coenzyme A mutase as a cofactor, and this is forming as a myelin synthesis. This is why anemia and neurological symptoms can develop if we do have B12 deficiency. Now, let's see. Megaloblastic anemia, how the peripheral smear looks like. I already showed you some. We do have bigger size. We do have ovalocytes. We do have very darkly stained cells, so we have polychromasia. We do have hypersegmented neutrophils. That would be very, very informative. This is how you can identify an alcohol-induced macrocytic anemia from a megaloblastic anemia. In megaloblastic anemia, you do have hypersegmented neutrophils. In alcoholic, no. Other lab tests, as I mentioned that, for example, at the cellular level, homocysteine can be measured, the folate deficiency, and the methylmalonic acid, the B12 deficiency. Why is it important? Well, you know, sometimes if you work in a clinic, for example, this is not the first line when the patient, let's see, meets with the doctor. They go to the family doctor, and the family doctor, if they show that, okay, this patient, for example, has anemia, an elderly one, usually what they do, vitamin cocktail. Doesn't matter, let's give a little folate, B12, B6, whatever vitamin they can choose. Okay, for 1 week, fine, and after they're checking again the lab values, and anemia disappears, the lab values, let's see, proved, and the patient feels better. Now it's cured it. Well, not exactly. Because if the patient had B12 deficiency, this treatment should be continued for at least 3 months. Because at the cellular level, the B12 is only, let's see, refilled, let's see, slower. So the patient still has neurological symptoms. Okay, so the patient goes to the physician, goes to a neurologic clinic, and what they found, let's measure B12 level. It's normal because they just injected B12. However, at the cellular level, the B12 is not efficient to produce normal, let's say, myelin. So this is why the methylmalonic acid level should be measured as well to see whether at the cellular level they do have a normal function or not. Another thing, if somebody does have B12 deficiency, when you give folate, anemia disappears. Yes, for sure, because the DNA synthesis needs folate, active folate cycle. And when you give the folate, the active folate, DNA synthesis normalized, but not the myelin synthesis. So you can worsen, for example, the clinical symptoms of B12 deficiency, neurological symptoms, by giving folate to the patient. Anemia disappears, and you do have still the neurological symptoms. Now, if you don't cure the patient within 1 year, that's the irreversible damage of the neurons, completely knocking out, and there's no turning back, and the patient will have an irreversible, let's see, walking disorders. Now, as I mentioned that we can have autoimmune origin of this B12 deficiency when we do have, for example, the most common one, parietal cells antibody. Parietal cells antibody is very sensitive, however, is not so specific. So it's almost every patient, almost 90% of the patient has this kind of antibody, but about 50% that can be, for example, the specificity. The opposite in intrinsic factor antibody. Intrinsic factor antibody, that is very, very, for example, specific, but the sensitivity is not too high. So the sensitivity, for example, is only 50%. So this is why these both should be measured. Now, long time ago, and in any kind of books, you can read about the Schilling test. That was a test that they diagnosed, how they diagnosed pernicious anemia. Today, they are not going to do it. But everybody is asking you. And I don't know why can you find in the most modern book the Schilling test, because this is a very sophisticated and time-consuming process. Now, what the problem is? Schilling test is going to evaluate the absorption of B12. So you measure the B12 level, that was low. To figure out whether this is due to abnormal absorption, what they do? They give parenterally cold, unlabeled B12. By this injection, they are going to saturate, let's see, the stores of the B12. After, they are going to give orally B12, radioactive B12. And they are measuring how much is urinated out, because it cannot go to the stores because stores are saturated, so it's going to urinate out. If you urinated out more than 16%, fine, you know that patient completely normally absorbed B12. If not, repeat the test using intrinsic factor and B12, and when you normalized, fine, you had pernicious anemia. If not, because that's another possibility, well, possible you have too much bacteria or worm, for example, hookworm infection, for example, in the intestine, that's using up the B12. In this case, the third phase, what they do, they are going to use a wide spectrum antibiotic or an anti-parasites, for example, drug treatment, and repeat the test. When they normalize, they say that that was a blind loop syndrome. If not, malabsorption. So something in the terminal ileum, some inflammation, chronic inflammation is going on, and this is why the B12 cannot be reabsorbed. This is how they are going. Now, this is how the bone marrow looks like. we are not going to have bone marrow smear for the final one. We used to have it, but now we won't have it. We have only peripheral. But as you see here, erythropoiesis increased, meaning that the ratio of the myeloid and erythroid precursors now is changed. Normally, we do have more myeloid precursor than erythroid, 3:1. Here we can have 1:1. So immediately when you look at the bone marrow, you do see that blue cells, blue big nucleated cells. So that means megaloblast, erythroid megaloblast. But not only the, let's see, the erythroid cells are big, but the myeloid cells as well. And these giant band or hypersegmented neutrophils can be. Plus, look at inside the red blood cells, it's tiny one, but you do see some nuclear dots. This is called Howell Jolly body. So these are the characteristic features of megaloblastic anemia. Let's see this second case. This is an 88-year woman, chronic gastritis in the anamnesis. After she had fallen at home, she was taken to the traumatology. Petrant break was diagnosed, but because of the pancytopenia in her lab results, the operation was cancelled and she was transferred to the Department of Internal Medicine. Let's see the bone marrow aspiration, what they did. They found that the erythropoiesis is characterized dominantly with the megaloblast. The mature forms are mainly cells with aberrant nucleus. The granulopoiesis shows severe maturation alteration. Myelocytes with aberrant nuclei or younger cells type are visible. Plenty of giant band cells. The ratio of the blast is yet within the normal range. The megakaryocyte number is less. The normal and hyperlobulated was hardly found. Opinion, megaloblastic hematopoiesis possible of the cobalamin or folate deficiency, but the lab value showed that this patient had a B12 deficiency. The diagnosis was pernicious anemia, and the therapy should be the B12 supplementation and transfusion, red blood cell concentrate and thrombocyte concentrate, and after the patient could be operated with these pathologic conditions. Good. Hemolysis. That's be the last one. Now, what hemolysis means? Hemolysis means that the anemia is due to the increased red blood cell destruction. Usually, this is normocytic and normochromic anemia. All right. If you do have a chronic one, you do have reticulocytosis. In acute, no. Only in chronic form, we do have reticulocytosis. Now, when this anemia is presented, only when we do have a decreased cell survival rate up to 20 days. So if the red blood cells lives only for 20 days, now it's manifested because the bone marrow can increase the production rate by 6 times. Now, due to the destruction, the intracellular content is getting out to the periphery, and we do have an increased LDH 1 and 2 activity. We do have an increased indirect bilirubin, and of course the urinary UBG level is increased. Hemoglobin and hemosiderin in the urine also can be found. Haptoglobin hemopexin is going to decrease if we do have an intravascular hemolysis. If it's extravascular, we won't have. In a smear, depending on the cause of hemolysis, if we do have a destruction, the extracorpuscular problem, we do have the fragmentocytes and spherocytes. If it's an immunologic origin, we are going to use the Coombs test, and that's proving that this is an immune-mediated process. Now, Coombs test, you learn it in immunology, I bet you. There are 2 types, direct, that is going to detect the antibodies bound to the cell surface. Indirect, they're going to detect the circulating antibodies in the serum. Doesn't matter which one is positive, you can say that this is could be the cause of. Now, based on the Coombs test, you can evaluate the patient. If you do have a negative Coombs test, it's not an autoimmune one, the next one you should detect whether that's an extrinsic problem or that's an intrinsic problem. Basically, if you do have an extrinsic one, you do have a fragmentocytes or the altered shape. That can be, for example, somebody has a prostatic vein, for example, or toxins or microangiopathy such as a TTP or HUS or HUS, or in intrinsic red blood cell defect, membrane defect, enzyme defect, glucose 6-phosphate dehydrogenase, pyruvate kinase deficiency, or hemoglobinopathies. Again, that can cause hemolysis. If it's an immune-mediated process, well, you can find warm or cold, or maybe Rh incompatibility, transfusion, or some kind of drug-induced problem. Penicillin can cause, chloramphenicol can cause. A lot of drugs can induce hemolysis and autoimmune hemolysis as well. Now, this is the summary of the laboratory ulceration in hemolytic anemia. Reticulocyte count increases, unconjugated bilirubin increases, LDH activity increases, haptoglobin decreases when we do have an intravascular hemolysis, urine hemoglobin is there, hemosiderin is there, urobilinogen is increased, and when they measure the C51 labeled red blood cell, let's see, live, that's usually decreased. This is what you can do. And further test to specify the underlying problem, hemoglobin electrophoresis. We said that if somebody has beta thalassemia, we do have a hemoglobin A2 level increase when we do have a 2 alpha and 2 delta chain in the globin. Hemoglobin F level can be, the fetal hemoglobin level can increase when we do have a 2 alpha and 2 gamma. Of course, excess hemolysis. Sickle cell anemia, we can hemoglobin S, you can detect it. In alpha thalassemia, we do have hemoglobin H when we do have 4 beta. Or BART, for example, hemoglobin when we do have 4 gamma. Now, you can detect, for example, the enzyme, glucose 6-phosphate dehydrogenase, pyruvate kinase, you can do it. Or we said agglutinin test, we can perform it. Or testing for cold agglutinins. Or osmotic fragility test. For example, the spherocytes are very sensitive to the osmotic stress, for example. Or paroxysmal nocturnal hemoglobinuria, when we do have a clone, when on the surface we don't have this piga that is going to regulate the binding of the complement cascade, these cells can be lysed in the night. And in the morning, we do have a hematuria. This is why this is a paroxysmal, because when every red blood cell takes about 7 days. So these clonal cells, every 7 weeks or so, we do have 7 days, we do have a hemolysis. Or if we do have an extravascular one, for example, DIC. It can be a chronic. How do you detect? D-dimer level should be checked. And you can see immediately that the hemolysis is due to some